Welcome to the Geriatric Lecture Series and this topic today on diagnosis and management of pain and dementia. I'm Keela Herr. I'm Professor and Associate Dean for Faculty at the University of Iowa College of Nursing and Co-Director of our Some Center of Gerontological Excellence. This is my disclosure statement just to let you know that I don't have any financial interests that would be in conflict with the content that I'm going to be presenting to you today. The objectives for this session include focusing on discussion about what is the problem of pain in older people with dementia, what are some of the challenges with assessing pain in that population, and some strategies for how we can do that based on best evidence available that we have. I'm also going to talk about approaches to treatment of pain in this population and share with you some evidence-based resources that you might find useful related to assessing and managing pain in older patients with dementia. I always start with framing the importance of this topic by looking at what's happening with the older segment in our population. And I think most people are aware that we are having a huge increase in the older cohort in our population, with an increase, almost a doubling, of the 65 plus population by 2030. Which means we're going to have more older people in our healthcare system to take care of. And along with that, then, is the increasing prevalence of dementia. So as the population ages, we're going to have more and more elders that are experiencing cognitive impairment, which are going to challenge us as healthcare providers in being able to recognize and treat pain effectively. I just wanted to share a study, a relatively recent study, that looked at what do we know about pain and its prevalence, particularly in the nursing home residents, which is where many of our persons with advanced dementia reside. And this study was across 6 nursing homes, but looked at recognition of pain across levels of cognitive impairment. And you can see from this slide that with increasing cognitive impairment, the identification or report of pain lessens. Well, what's significant about that is there are a number of studies that have showed that patients that are intact, cognitively intact, and those that are cognitively impaired have similar levels of diagnoses that we know are painful. So there's really no reason to suspect that people with cognitive impairment don't experience pain from the same types of conditions. There's also evidence that pain is undertreated, and you can see here that those with cognitive impairment receive substantially less scheduled pain medications, which is a real issue. So in looking at some prevalence data across different care settings, on this slide I've just highlighted the nursing home, hospital, and emergency department and some key studies that looked at the prevalence of pain. And what you find is that pain is relatively prevalent of older adults in all 3 care settings, with about 50% having some pain in the nursing home population. In the hospital setting, on a geriatric unit, 2/3 had pain reported. And in the emergency department, looking at all pain-related ED visits, we can look then at pain treatment, and you can see here that half of the older adults received analgesics with a clear indication of pain in the emergency setting. In the hospital, half of the patients with pain were receiving no treatment or inadequate treatment, and in the nursing home, only a quarter of those with documented pain were receiving scheduled medication. So there is an issue with not only recognizing pain, but treating it effectively. Well, why is that important? If you look at the consequences that have been identified related to ineffectively treated pain or undertreated pain in older adults, we know that pain can interfere with sleep, which has a very strong relationship with chronic pain as an important consequence of ineffectively treated pain. It can impair eating and nourishment. It interferes with the ability to interact socially and recreationally in the things that are important to quality of life. We know that pain can impact physical function, impair rehabilitation, and can actually contribute to falls. And it's also strongly related to cognitive issues such as depression, anxiety, and untreated pain can actually increase impaired cognitive function, the development of delirium. These are all factors that are important when we look at use of healthcare utilization and costs, but most importantly, interfering with quality of life. One of our challenges is that in people with dementia, we're not certain about how to evaluate impact on quality of life and function, and so this is an area where we need further research. So there's evidence that this is an ongoing and continuing challenge, that ineffectively treated pain in long-term care in particular is a real issue for us societally. And there are a number of misperceptions that I think have contributed to this problem. One is that people think that cognitively impaired elders don't have as many pain-related conditions, and we have clear studies now that document that the prevalence of pain-related problems is similar. I also hear from providers thinking that if you're cognitively impaired, you don't experience as much pain. And our studies also show that this is a myth, and that those with cognitive impairment experience the pain sensation similarly, but they don't know how to interpret it and process it. I also have heard that if they don't tell us that they're hurting, then they must not be having pain. And again, this is kind of at the crux of being able to recognize pain, is we can't assume that just because they're not expressing their pain verbally and in words, that they're not having pain. And then finally, a myth or misperception that we can't assess pain in people that can't communicate with us. And I'm going to share in the rest of this session what we do know and how we can identify and assess pain in this population. Okay, just a few points about pain and dementia. We've learned from recent studies that the experience of pain is similar in the transmission of the pain stimulus to the brain in people with dementia compared to those who are cognitively intact. Where there are variances is in the interpretation of that pain signal, and understanding that this is pain and putting some context around it. So it impairs their ability to interpret and process the pain sensation. Other current studies have shown that people with dementia have a blunted response, autonomic system response to acute pain, and this is different from in other age groups where we can usually use that autonomic nervous system response as one indicator of acute pain. That's not common in people with dementia. So from what we know about the experience of pain in dementia, we have to assume that the prevalence of pain is the same and the severity is the same as in those who are cognitively intact. So what are some of the key factors that are impacting our undertreatment of pain? And from my perception, the biggest reason is a failure to assess pain, to identify and assess it, because that really is the guidance to the development of a treatment plan. If we don't know pain is present, we don't know to treat it, and we don't know how to develop a treatment plan from that. So consistent and continuous assessment of pain is a key factor that we need to continue to promote. This slide just is a graphic of some of the domains of assessment that go into doing a comprehensive assessment of pain in older people. You can see there's many different elements that are considered here. Initially, one of the key things that we look at is the self-report of pain, and getting measures of pain, reports of pain that guide our decision-making about treatment. There are also other areas related to history I'm going to go into in a little while. Their prior experience with pain, what medical conditions they have, doing a good functional assessment, looking at factors that are going to impact the treatment plan, and considering psychosocial factors as well. And there are a variety of different tools for assessing each of these that we're not going to have time to go into all of them today, but it's important to understand that when you look at assessment of pain, there's a comprehensive approach that's important, with determining presence of pain one of the key elements. This slide reports on a study that documents the ability of persons with dementia to self-report their pain. And what you can clearly see here is that in those with mild and even moderate cognitive impairment, the majority of older people are able to self-report. It's not until some of the more advanced or severe levels of cognitive impairment that the ability to report pain decreases. Do we have reliable and valid ways to assess pain in cognitively impaired, particularly using valid and reliable pain intensity tools. This is a study that was done across patients in a geriatric hospital, and what you can see if you look at the graphs is that, again, with normal and mild and moderate cognitive impairment, the ability to use the common pain scales is still intact. It's not until severe impairment where none of the tools are able to be completed, but you can see a downward trend in the numeric rating scale, the number scale. So the recommendation does seem to be very appropriate to use a word scale, because people with cognitive impairment can use that for much longer periods. It would be great if there were reliable physiological measures of pain in this population, particularly because some of the ways that we try to get information are challenging. And there are really interesting studies going on right now that are looking at biomarkers, using functional magnetic resonance imaging, and other techniques to try to gather information about pain from a population based on these physiological measures. We're not to a place yet where these are common practice, but there is a lot of work and research going on that I think in the future is going to help us to be able to recognize pain when we have to rely on nonverbal mechanisms. So I just wanted to frame the goals of assessment, and I think key is just to recognize the existence or presence of pain. Ideally, we want to characterize it by type and quality, location, intensity, and cause if we can, because those provide key information to guide our treatment planning. Historically, in most populations, the most reliable indicator of the existence and the severity of pain is what the person tells us. In the population with dementia, particularly more advanced dementia, we can't rely on that. We have to look at other measures. And then a third goal, I guess, of clinical assessment is to identify the impact of pain on function and quality of life. It's not just that pain exists, but how is it actually impacting their ability to do the things that are important. So I want to focus specifically on those with severe cognitive impairment now, and how can we assess pain in that population. So I was part of a group that developed a hierarchy for pain assessment techniques specifically for patients who are nonverbal and unable to self-report. And there are actually 5 different elements of that process that we encourage clinicians to think about. The first is that you still have to try to get self-report. And because the earlier slide showed you that even those with moderate cognitive impairment might be able to self-report, it has to be part of the step. Second, looking at potential causes of pain, things that we know are painful and those that can self-report to us, diagnoses or conditions. I'm going to talk a little bit more in a future slide about this. Looking at pain behaviors, and pain behaviors to me are a way that the person with dementia does communicate what they're experiencing. It may not be in words, but it may be in other behaviors that we can interpret. Surrogate report can be really important, particularly in looking at changes from baseline in their behavior and activity. And then finally, the last step in this is if we think pain might be a problem, but we really are not certain, we can use an analgesic trial, and I'll talk a little bit more about this. And that is using an analgesic as a validation technique to see if what we're thinking is pain-related behavior might actually respond to treatment. So I'm going to go through each of these a little bit. In self-report, attempts should be made to try to get self-report. And again, even a head nod or some simple way, even a yes/no, are you having pain, we might be able to get a report. It's also very important, if you can't get self-report, to document why not and what method you're using to evaluate pain in this population. The second step in the process is to look and search for potential causes of pain, and the history and physical exam is really key to this. Ideally, we would want to identify a definitive diagnosis that could be causing the pain, because that will help us to target treatment, but that's not always possible. So thinking about do they have other pathological conditions or experiencing procedures that we know are painful? Do they have infections or inflammations? Urinary tract infections, old fracture sites, surgical incisions? Are they experiencing wound care, rehabilitation activities? Just kind of try to think broadly about what might be contributing to a painful experience. It's helpful to think about common sites of pain in older adults, and we know that musculoskeletal and neurological focus are the common types of pain in this population. Related to diagnostic tests and laboratory tests, their use should be cautiously used. If they will help clarify and define a diagnosis, yes, but if it's not going to make a difference in the treatment planning, we try to minimize those. And then it's important to be aware of coexisting diseases and medications that might be impacting the pain experience and certainly have an influence on the decision making that we have related to treatment. So this slide just highlights for you some of the sources of persistent or chronic pain in older adults that are common. I think being familiar with the kinds of musculoskeletal, neuropathic, and other types of conditions that older patients might be experiencing kind of helps in the detective work of looking to see if there's something going on that might be painful for that person. As I mentioned earlier, physiological indicators in older persons, particularly those with dementia, are not very reliable. We definitely would not use this for chronic pain, whereas some of the indicators, the physiological indicators that are useful in acute pain may not actually be appropriate for people with dementia. So I think the bottom line is that the absence of vital sign changes doesn't indicate the absence of pain, but if they're present, it may support that diagnosis. So in thinking about behaviors related to pain in the population of dementia, one thing that has become clear is that we have to look for less obvious behavioral indicators of pain, and these may occur in both nonverbal cues and observable behaviors, in vocalizations, and in facial expressions. And on this slide, I'm just highlighting the yellow indicators are those that are more common that we typically consider that indicate pain. But you can see there are other things like fidgeting and rigidity and increased pacing, or chanting out, yelling out, swearing, being verbally abusive. And facial expressions may include things like rapid blinking or distortions. So it's thinking a little bit outside of the box as far as indicators that might represent pain. It's also clearly documented that if we're looking at behaviors that might be pain-related, at rest we're not going to recognize them because they're not being stimulated by activity. So we really want to be looking at behaviors during movement, like transferring, sitting up, dressing, activities of daily living, bathing, are the best times to be doing behavioral observation, as well as looking at changes in behavior that might occur in their typical daily activities and interactions. So those might be in interpersonal interactions. We might see increased aggressiveness, resisting care, disruptive behavior. We might see changes in their patterns of activity. Suddenly you see that they've stopped doing something that was a routine activity, or they may be sleeping more, sleeping less, refusing to eat, those types of changes. Or you might see changes in mental status as far as more irritability or distress or anxiousness, increases in confusion and agitation. Any of these kind of changes can suggest that pain might be a cause, although they're not specific for pain. So one of the things that we are trying to encourage is the use of a pain behavior tool that helps focus behavioral observations so that it can be done consistently across provider and observer. And having an identified tool that's used in your institution can advance this effort. And it also helps with documenting assessment in a way that can be monitored over time to observe if behaviors are improving with treatment and to communicate across provider and across setting. So some general recommendations about the use of behavior pain assessment tools are that you've got to pick a tool that's appropriate for your population. There are many tools available, and I'm going to share some recommendations with you in a few moments. It's also important to understand that at this point you can't use a behavior tool the way you do a pain intensity tool. it's not clear for many tools what level of behavior on a tool indicates mild, moderate, or severe pain. It is clear that as behaviors increase, pain is increasing, and as behaviors decrease, the pain is decreasing. But you can't say that a certain number on a tool is a certain level of severity. So you use these tools with an individual patient and use them consistently, looking for changes of increasing behaviors and decreasing behaviors and how those behaviors change in response to treatment. So are there reliable and valid tools for pain behavior assessment in those impaired older adults? And yes, there absolutely are. In fact, over the last decade, over 25 different tools have been in development and with various stages of testing. There are a variety of reviews that have been published that critique the tools and make recommendations on those that are most appropriate or have the strongest psychometric properties. But what we find is that there's no single best tool for all settings. And in fact, most recently was a publication which critiqued the critiques of these tools, and they also concluded that there's not one single tool for all older adults across all settings. But there are some that have been stronger, and I'm going to just share a couple of them with you here. The PainAD or PainAD was a tool developed in the VA setting, and it's a system of looking at 5 different behavioral qualities and rating them on severity. It comes up with a 10-point scale. This scale has a fair amount of psychometric testing, and it's been used across acute and long-term care settings, and it was one that could be used. This is the PACS-LAC2, which is another tool which is different from the PainAD in that it does also tap into changes in behavior and activity, which the PainAD doesn't do. They're a nice complement of 2 different tools that can be used consistently over time to be able to monitor for changes in behavior. When you do compare some of the existing tools, I just wanted to share this one study that compared 6 tools that are probably some of the stronger tools in the literature right now. And what you see here is that the 2 tools that I just shared, the PainAD and the PACS-LAC, both were strongest as far as recognizing pain and detecting changes in pain based on different types of conditions. And some of the research that's going on right now is looking at, can we identify key behaviors? Is there anything that really stands out? And facial grimacing and recognizing pain indicators facially is becoming a very important element of most of the tools and in a focus of what we should be looking at. This is just another study that compared a variety of tools looking at the facial action changes that occur with pain. And you can see on the bottom of the slide there's several tools that identified grimacing activities very importantly. And the 2 tools, the PACS-LAC and the PainAD that I showed you, are also part of those that are recommended based on that. Other areas of research in this area are starting to provide some nice evidence about atypical pain behaviors that I talked about earlier, particularly agitative, disruptive, restless behaviors. Bettina Husebo and her group in Europe has done a really nice job with some really well-designed randomized control trials to look at treatment of those behaviors as if they're pain and determining if indeed those behaviors improve as a part of a pain treatment plan, and has definitely demonstrated that yes, these behaviors can be responsive to pain treatment, suggesting that they may be actual indicators of pain. I mentioned earlier about the challenges with pain severity and having cutoffs that indicate level of pain, and this is an area where there is ongoing work. In fact, some of the research that the group that I work with is doing is trying to identify if there are ways to determine pain sensitivity or intensity based on changes in behavior intensity. So this is ongoing work, and hopefully in the future we might have more guidance about determining level of pain based on pain behaviors, but we're not quite there yet. So I mentioned that surrogate reporting of pain is an important element of the assessment process, and what studies have shown is that surrogate reporting is important, and it can help us understand changes in pain and pain behavior. But the studies clearly show that surrogates, whether it's a healthcare provider or a family caregiver or nursing assistant, can be accurate in recognizing presence of pain, but not in judging the severity of pain. So looking at potential pain indicators, this is kind of a quick overview. If you have behaviors that we think are pain-related, there are things that we then need to do. We need to make sure their basic comfort needs are met so that the behaviors are not really related to other things that can be readily treated, such as hunger or thirst or repositioning. Then validating, again, if there are other causes of that pain that could be treatable of the behaviors that we're seeing. Trying non-drug approaches related to those behaviors that we're seeing. These are the things that we normally would do with people with dementia when we see agitated and disruptive types of behaviors. So if we try to treat those with environmental adjustments, do those behaviors improve? If so, then it kind of moves away from thinking that those behaviors are pain-related. And then finally, though, if we still have questions of do these behaviors indicate pain, an analgesia trial is the recommended approach. And that is treating the pain or the behaviors as if they're pain-related. And so there's a really nice algorithm that was developed in Europe and has been tested in a randomized controlled trial, treating disruptive behaviors as if they're pain-related. And you can see the protocol on the right, starting with acetaminophen, moving to a morphine or buprenorphine, and if neuropathic pain is suspected, pregabalin treatment. And here's what the findings were in this group of moderate to severely demented older people with behavioral disturbances. You can see on the top bar that the control group behaviors stayed the same during this treatment period, but those that received the analgesic treatment clearly showed an improvement and a decrease in those behaviors, suggesting that the behaviors were actually indicators of pain. So this is a really important path to validate whether or not the behaviors are pain-related, and then from then you step back and develop a treatment plan going forward. I did want to share that in this trial, the majority of individuals responded positively just to acetaminophen. It didn't even require some of the stronger medications that we have in our treatment portfolio. So really, the judgment about pain in this population is kind of being a detective and putting together the pieces from a variety of different sources of information. So using self-report if possible, looking at history and potential causes of pain that we know are painful and those that can communicate with us, doing a behavioral assessment either through direct observation or gathering information from surrogates, and using an analgesia trial to confirm suspicions if there is still uncertainty about whether or not the person's experiencing pain. It's important in an organization to have a process for assessing pain in this population. Having identified tools that are used for this population, that are used consistently across provider and across the different shifts and settings within the organization is really important for follow-up documentation of improvement or deterioration of their pain situation, and that this needs to be clearly documented. There are resources, guidelines, and position statements on assessment of pain in older adults, and I've highlighted several here for you for accessing more detailed information than what I've been able to provide here. I've tried to provide some highlights, but these are really excellent resources to access that I think will be helpful to you if you want more information and guidance. So I want to shift now from assessment to treatment of pain in this population. And especially for chronic persistent pain, it's really going to be important to approach this from an interdisciplinary perspective and to establish what the goals and priorities are for that patient. And in setting the goals, it's very important to involve the patient, but if the patient has advanced dementia, they're not going to be able to participate very clearly in goal setting. So we do need to bring in family or other surrogates to help in setting our goals and priorities for that patient. The team needs to be broad, and we need to be including the direct caregivers, therapists, social workers, nutritionists, consultant pharmacists, the primary care provider, in coming up with a plan of care for the older person with dementia. Our focus in developing a plan is to use both pharmacologic and non-pharmacologic approaches to assure that we're doing quality assessments to guide the treatment planning and to be able to evaluate the effectiveness of our interventions, that we optimize non-drug treatments as well as analgesic treatments, and minimizing adverse effects of analgesics and any potential risks that might occur from using different types of analgesics, and that we document clearly what we're doing and the response to the different treatment approaches that we use based on the behavioral observations that we're doing. So some kind of key targets related to treatment is that all patients that have functional impairment or diminished quality of life as a result of persistent pain should be candidates for both non-pharmacologic pain management and pharmacologic therapy, and the integration of these treatments is important. Age shouldn't be a factor. However, cognitive impairment is a factor. It has to the type of treatments that we're going to be able to use effectively. I'll talk a little bit more about that. So I want to frame some of the barriers to pain management in this population, and many of these apply broadly to older adults. But polypharmacy is a big issue. Many of the older adults have comorbidities that impact the type of treatment that they're able to receive as far as analgesic management. Also, the many medications that they might be receiving can create drug-drug interactions and compliance issues. You know, the average older adult is taking 7 to 12 different medications, and so if we're trying to add analgesics, it complicates that plan even more. Cognitive impairment itself can be a challenge in pain management. So not only can it interfere with assessment, but it also can interfere with compliance to a treatment plan, what non-drug interventions the older person is going to be able to comprehend and utilize. Opiophobia is a barrier to pain management that crosses older adults and including those with dementia. There's a big fear about addiction and side effects related to the use of opioids, and so this is certainly a consideration that needs to be taken into effect. And finally, physiological changes that occur with older adults. You know, there's certainly increased frailty. They may be more responsive to analgesics, and so dosing and monitoring of effect is very important. And I mentioned already, you know, cardiovascular, renal, liver issues can be common in this population, and that certainly guides then the kinds of analgesics that we can use or that might put the person at risk that we have to be monitoring very carefully for. I'm highlighting on this slide some of the non-pharmacologic treatments for consideration in this population. The ones in yellow are those where we have the most evidence to support their use in older adults in general. Educating the patient, making them informed about their pain treatment and how we're proceeding. Exercise is, strongly recommended for chronic pain conditions. Self-management, coping strategies, cognitive behavioral therapies are very effective in older adults. Their use in those with dementia, of course, are probably going to be somewhat limited. But things like distraction and relaxation therapies can be readily used in the person with advanced dementia. I've also listed some other non-drug treatment options here that can be considered. Again, we don't have a lot of evidence on their use with those with dementia. These are some recommendations for comfort measures for older adults that can have a pain-relieving effect, such as distraction, storytelling, music therapy, relaxation, touch, warmth, massage, using cold and heat as appropriate to the pain problem. Even repositioning can be useful. With movement and exercise, we know that that can be important with chronic pain, and there are some things that have been tested in people with dementia, such as the use of glider rockers. pet therapy, things that sensory stimulate their senses. And with cognitive therapy, it may be simple things like reminiscing with them. Reading and visiting therapies can be useful. The research on cognitive behavioral therapy in older adults with chronic pain is gradually growing. I'm just highlighting here some of the areas where we want more information. We want to be able to understand the application of some of the non-drug cognitive behavioral therapies in real life administration. We don't know a lot about their use in frail or cognitively impaired elders, so this is an area we want to develop. When and who to use or select these treatments for, how do we adapt them in a way that makes them useful and accessible? What are the patient's preferences is also kind of key. And for many of the non-drug interventions, we really don't know a lot about how to sustain effect over time. They work effectively while you're using them, but for chronic pain that's ongoing probably for years, we don't know well how to use these therapies to get long-term sustained effects. So I want to talk a little bit about principles of pharmacological treatment. The guidelines, and these are recommendations from the AGS persistent pain guidelines that are still applicable today. Clearly we want to find the least invasive method and identify analgesics that are going to have the lowest adverse effects, lowest interaction effects with other medications, starting with a low dose and advancing as necessary, trying to match the timing of the administration to the characteristics of the pain. If the older person has a chronic pain problem and has cognitive impairment, using a PRN approach is not going to be effective. We need to have scheduled medication that's going to provide consistent relief over time. And again, anytime we think about pharmacologic treatment, we also need to be considering non-pharm intervention and what we can use that might synergistically improve pain treatment. And finally, multiple drug therapy can be helpful, but at the same time, we have to be looking at drug-drug interactions and trying to minimize the numbers of medications that we're trying to implement in their treatment plan. The American Geriatric Society has updated the Beers criteria, which is a list of medications to be avoided in older adults based on current evidence of risks and concerns. There's many medications on here that you're probably familiar with: the meperidine, indomethacin, ketorolac, pentazocine, not recommended. Skeletal muscle relaxants can cause a lot of issues as well, so they're not recommended. But a couple of the newer ones that have been added is the use of non-steroidal anti-inflammatory medications. These now have an avoid for chronic use because of some of the concerns, not just the bleeding issues and the peptic ulcer issues, but also now the cardiovascular risk that comes with this medication class. And then for opioids, this is also a newer medication added to the avoid or use with caution. And the recommendation is to avoid opioids in the history of falls or fractures because there has been some association with both of those conditions with the use of opioids, except if there's an acute pain problem for which they're needed. So caution. In summarizing treatment recommendations in older adults, it seems that using acetaminophen as first-line therapy is still the best and strongest approach to use in treating this population. Consider topical agents for localized pain, and many of the non-steroidals now come in topical applications, and so that does minimize some of the systemic risk of non-steroidals. So that's a second-line approach. Non-steroidal oral non-steroidals should be used rarely or only with extreme caution. Consider adjuvants such as anticonvulsants, antidepressants if neuropathic pain is a problem, and opioids still may be a part of the treatment plan with moderate to severe pain. The guidelines, though, have to be individualized to the person and tailored particularly for those with cognitive impairment, and thinking about some of the dosing issues that are necessary when you're working with a population that can't tell you what they're experiencing. Integrate non-drug therapies, as I mentioned. I think consulting pharmacists can be extremely important because of the complexity of polypharmacy in this population, and educating maybe not the patient with advanced cognitive impairment, but the family, and getting them on board to help with implementation of the treatment plan. I wanted to share this resource because of the concerns that have arisen lately about the opioid epidemic in America, and how does that impact our treatment of older persons with persistent pain. And I edited a series that was published in the Journal of Gerontological Nursing on this topic. And there are some really key papers on opioid misuse and abuse and its impact on pain management, how to approach pain care under this kind of a global concern about opioid misuse and abuse and deaths. Focus on what's the evidence for complementary and alternative therapies for persistent pain, and then recommendations for pharmacological management of pain in the population of older adults. So I think these are some key resources that you might be interested in. There are also guidelines that go into much more depth on pharmacologic recommendations and approaches to the management of pain, both from a non-drug and a drug perspective, including the Beers criteria, that I would encourage you to access. Here's a couple more as well. The top one is the British Pain Society and the British Geriatric Society published a guideline on management of pain in older people, and that's probably the most recent one that has kind of an overview of guidelines, so you might be interested in accessing that as well. I wanted to share a resource that I've led the development of with a group of national experts to provide best practice resources and tools for caring for older patients with pain. The website is geriatricpain.org, and if you go there, there are a variety of resources related to pain assessment, pain management, education for clinicians, quality improvement, and a new section that we've just added on resources for caregivers and patients. Each of these sections has a wealth of information, guidelines, and tools and resources and educational tools that can help you individually, or if you are in a position of staff development. There's a lot of resources related to training and development of staff. I'm just going to show you a few things. For example, this is the pain assessment link, and you can see a listing of different resources that you can go to. There's PDFs so that you can download them and use them in your organization directly, such as this. This is the pain ad tool, and it's in a format that's ready to download and use with permission to use it in your facility. This is an example of a pain management communication tool that can be used particularly to fax to a provider key assessment information that will guide in the decision making about treatment. This area, which is under pain condition management, we have a variety of fast facts focusing on different pain topics, and these are short 1 to 2 page tools that can be used for education of staff about a variety of topics. This is an example of one of our management guides. We have a variety of these on different topics, and I'm just going to show you through a sequence of slides here what each of these includes. So this is on joint pain. And the problem is defined. There's some discussion about the problem, some of the key information about causes, signs, and symptoms that you would be looking for, and some management caveats. There's guidance on physical examination. What are some of the key things to be looking for and doing as a part of the physical exam process? And then some of the initial nursing care and what needs to be communicated to providers that would then guide the primary care provider or practitioner in moving forward with the treatment plan. And then an overview of what some of the treatments are for this particular problem and some key references. So each of these management guides has a pretty nice summary of key information, whether you're a primary care provider or the nurse, and even for family members. This is an example of one of the fast facts. This is a 1-minute pain assessment that's ready to download, and you could post it in the bathroom or patient education area. We want these to be useful tools for you in your facilities. So please visit geriatric.pain.org and look at some of the resources that are available. They're free and available for anybody that wants to use them. So to bring this session to a conclusion, I just want to empower each of you to be an advocate for the older patients that you care for those with dementia who can't communicate about their pain, who can't advocate for themselves. We have to be the detectives. So we have to be aggressive in looking for indicators of pain, trying to validate those, and then assuring that a treatment plan is put in place to make sure that our older patients with dementia have the best quality of life possible until the end of their life. So thank you for joining us today, and I hope this was helpful and informative to you.